So I start a brief introduction. So Dr. Ozlem Uzuner is an associate professor at Information Science and Technology Department of George Mason's University. She's also a research affiliate at Computer Science and Artificial Intelligence Laboratory of MIT. Dr. Uzuner specializes in natural language processing and its applications to real-world applications, particularly healthcare and policy. Her current research interests include information extraction from fragmented and ungrammatical narratives for capturing meaning. So studies of consumer-generated text such as social media, which is quite relevant to a lot of research we have heard so far, and a lot of healthcare-related applications, I believe, and also semantic representation development for phenotype prediction. Her research has been funded by a National Institute of Health, National Library of Medicine, National Institutes of Mental Health, Office of National Coordinator, and by industry. So what we are going to do today is I'm going to play a pre-recorded presentation. So let me share my screen.
Good afternoon. Today, I have the pleasure of telling you a little bit about the work we've done in the last few years about building semantic representations of clinical records. As is very well known by this audience, clinical records contain a wealth of information that describe what happened to the patient, any actions taken by the medical team to care for the patient, as well as the rationale for the actions taken and outcomes of the care. This way, future care can build on the past. Now, as you can imagine, based on the context in which these notes are produced, they present unique linguistic challenges. As these notes are written for the doctors and by the doctors, they assume shared domain knowledge and expertise in their audience. As a result, the documents are filled with jargon and shorthand notations, acronyms, all of which can be interpreted in their context by the experts. They also make no effort to convey facts in a grammatical way. Just get the facts efficiently and effectively down, even if you're writing in a telegraphic way, so that the care can continue. In order to open up these clinical records to downstream applications, we need natural language processing solutions that can, for example, connect coronary artery disease here to its acronym CAD, that can connect upper GI bleed here to its cause, gastric ulcer, and then can even tell that the biopsy mentioned here has not in fact taken place in the case of this patient. If we can build such semantically rich representations, then we can really rely on those representations to create summaries of these documents and use them for downstream applications. Example clinical applications include finding cohorts of patients for clinical trials, for example. Instead of waiting for patients to self-identify or be directed by their physicians to clinical trials, we can use existing medical records and we can identify cohorts of patients that can match certain clinical trial eligibility criteria. We can build better decision support using the existing clinical record data to study what actions have been taken and what outcome they have given in a certain clinical setting, so that information applied to future patients can build on both the domain knowledge and experience of the patients in a certain clinical setting. We can use the information for early intervention by identifying patients and their health trajectories, given what's documented in the records, and we can even personalize treatment. There are some challenges to building semantically rich clinical NLP systems. Today, I'll talk about 4 of them. 2 of them are procedural. These are access to data and availability of gold standard. The other 2 are scientific challenges, and they are the tasks that I see us trying to handle in the next few years to move the domain forward. Access to clinical data is limited by privacy concerns. And this makes sense because health data are sensitive data. and we need to be careful about how we use them and what we do with them. However, the privacy concerns can be so limiting that the required natural language processing systems end up being developed by individual in-house teams on the specific data sets that come from their own home institutions, or maybe at most affiliate institutions. And this has great value because these systems perform really well on the data for which they are developed, and they serve a great purpose. However, from NLP perspective, the systems developed on different data sets end up not being comparable to each other. And this presents challenges for identifying the state of the art and for building on it. Since 2006, I have had the privilege of working with Harvard Medical School and Partners Healthcare, who had the vision to share de-identified clinical records with the research community for enabling secondary use applications supported by clinical NLP. This team worked with their legal team and institutional review boards and have been releasing cohorts of clinical records to the research community with data use agreements. This has enabled head-to-head comparison of methods developed on the same data and for the same purpose. To support the head-to-head comparison of systems, generating gold standard annotations has been part of the effort we have undertaken with Harvard Medical School and Partners Healthcare. We generated gold standard annotations both for building block NLP tasks and for clinical applications of NLP. Since 2006, we generated gold standard annotations for 21 NLP tasks. So here you see there are 9 rows times 2 is 18, and there are multiple tasks in some of the rows. So I counted 21. We generated gold standard annotations for a variety of tasks. These included both information extraction tasks such as de-identification, medication extraction, and adverse drug events extraction, as well as document level classification tasks such as obesity diagnosis and smoking status classification. We considered both building block NLP tasks such as concepts and relations extraction, coreference resolution, and temporal relations, which tend to be agnostic to clinical applications and can support a broad range of secondary use cases. We have also considered specific medical applications such as obesity diagnosis and symptom severity classification from psychiatry notes. Our data over the years have come from multiple institutions. Partners Healthcare, which is the institution that started this whole thing, is still the primary donor of data to our efforts. Over the years, NUIC has donated data multiple times. UPMC has donated data. And more recently, Mayo Clinic and University of Washington have donated data to our annotated gold standards. These data have been shared with the research community through shared tasks. Shared tasks allow head-to-head comparison of systems that are developed on the same data for the same application, and they allow us to evaluate those systems on the same held-out test data so that we can see where the state of the art really stands and how we can build on it. The shared tasks that we have been running since 2006 both addressed our concerns of data and gold standard availability to some extent, enabling the field to move forward, but they also allowed us to identify open research questions for the community to seek out in their next steps. So I'll talk about variability of data and complexity of domain as 2 of those challenges for us to focus on next. But before I do so, I want to share some observations from the last few years of shared tasks. One observation is that for clinical concepts, we seem to be doing consistently well. In 2010, we were focused on medical problems, treatments, and tests as concepts, and F measures reached 92%. In 2018, we were focused on adverse drug events and the entities related to them, and F measures reached 94%. This is consistently good results, and regardless of the differences in the concepts that are extracted or the nodes that they're extracted from. I think that's great news. We seem to understand concept extraction task, and we have built reliable methods that will address it in different contexts. Now, for relations, the performance jumped from 0.7 to 0.9 in the 10 years from 2010 to 2018. Part of the reason for this jump is, of course, deep learning. Whereas in 2010, the best system was a support vector machine. In 2018, pretty much all of the systems that tackled relation extraction used BiLSTM CRFs with great results. Another task that we ran multiple times over the years is de-identification, and it allows us to check on the state of the art from year to year by comparing performance. Here I have summarized the results of our shared tasks on de-identification in 2006, 2014, and 2016, and I'd like to highlight that all results are above 90%. I am right now less concerned with the fact that these numbers seem to be going down over time, because time isn't the factor that is affecting those numbers, and those numbers are in fact the inspiration for the next set of steps we may need to take in de-identification and in clinical NLP to improve the state of the art. Now, before I go any further, let me back up and make sure that we are all on the same page about de-identification as a task. This is a named entity recognition task, in which the entities that we are focused on are those entities that are defined by Health Insurance Portability and Accountability Act as being private health information. HIPAA defines 17 pieces of textual private health information that need to be removed from the records in order for the records to be considered de-identified. These information include names, ID numbers, phone, fax numbers, locations, dates, etc. De-identification is a task we had to tackle ourselves multiple times during our data releases. Every time we wanted to release a new batch of data, we needed to de-identify them, and that presented an opportunity for us to rerun the de-identification task. However, over the years, the task evolved a little bit. Whereas in 2006, we stuck strictly to HIPAA categories, in 2014 and afterwards, we defined a much more fine-grained de-identification schema that allowed the hospitals to have the flexibility to decide at the time of use how much of the PHI they wanted removed from a data set for a particular use. You can imagine there can be internal uses of the clinical records within a hospital that may not be possible if all the PHI are in the records, but removing certain PHIs may enable those applications, yet some of the PHI may be left in the records so that they can benefit the downstream application. So the task definition is one of the explanations for the differences in the performance in the three results that we have seen in de-identification. Another explanation is the data type that are used. While all of our de-identification data came from Partners Healthcare, the first set was discharge summaries, which is a coherent group of notes of the same format and similar linguistic properties. Whereas 2014 data consisted of longitudinal medical records, which is a mixed bag of notes that contain progress notes, doctor's notes, patient-doctor communications, lab results, and many other types of notes. 2016 was further different. That was psychiatric intake records, which were primarily interview questions and long narratives of the patient's state. So the differences between the results that I've shown before come from primarily these factors: slight task description and the different kinds of notes. The differences of the de-identification systems on different note types from the same institution highlight the fact that we need to focus on the variability of the notes for our future steps. We can see that the notes vary from department to department within the same institution. They vary from institution to institution even further. The same node type can be different from one institution to the other. And as long as this is serving the primary purpose of record keeping for clinical care, it's okay. However, the differences between the node types change the nature of the NLP task and will require different systems. This is a problem for generating systems that generalize from one data set to the other. Intrigued by the differences in the node types and in the performance of DID systems, we ran some experiments, some within our research group, some with the research community. So just as a reminder from the previous slide, the 2014 best system was about 93% F measure using a CRF. So to check how the system performed on brand new data from the psychiatry department, we asked systems and participants of 2014 shared task to apply their trained system to 2016 data without training on any examples of 2016 data. The performance went down to 79% F measure. It's a reasonable decline. Again, still the notes from 2014 served as a pretty good start for de-identifying psychiatry nodes, but not as good as if you had in-domain data, which is what you see in the last line. Here, the teams had access to training data from 2016 psychiatry nodes and were evaluated on a distinct held-up portion of the same nodes in the form of unseen test data. The performance jumped back to 91%. Within our research group, we explored the variability of node types from one institution to the other. We utilized all of the notes that were available to us from Partners Healthcare through our shared tasks. And we also obtained and utilized a data set from University of Washington that came in the form of 10 different node types. We applied our state-of-the-art de-identification system, NeuroNER, to this task. NeuroNER is a BiLSTM CRF system that has performed really well in multiple tasks, not just DID. We evaluated our NeuroNER system on Partners Healthcare data and University of Washington data in the following way. We first split the University of Washington data into training and test portions, as we normally do. We baselined our system by training it on University of Washington data, training set only, and applied it to the distinct test set to see that we got 91%, which is consistent with all the other de-identification results in the 90s. Then next, we trained on a combined pool of Partners Healthcare data and applied the resulting model to University of Washington data. We got 78% F measure here. You may remember that when we compared 2014 to 2016 results, there were again about 13 to 15% decline going from one data set to the other. So this is interesting. We went across institution boundaries and the loss is again about 13 to 15%. I think that deserves a second look and a further investigation of why this is the amount of loss that we are getting. And I'm curious, I'd like to know more. Now, if we added some in-house University of Washington data to the Partners Healthcare training data, we would be able to jump back up to 90s. In this case, we considered how much University of Washington data we would need in order to jump back to the same level, and about 30% was the magic number. Mm-hmm. So external data can help you cut back on how much in-house data you would need to generate for your transfer purposes. If you are unable to obtain external training data, then if you can obtain models developed on those data, you are still in pretty good shape because you can fine-tune those models to your in-house data and you will be able to jump back to 90s in your performance. So I think this is great news for all of us in the NLP domain because it shows that if we can share data, we can really give each other a leg up. So without any training data from your own institution, you have a pretty good start at solving the problem. A small amount of institutional data can complement the external data. And if we cannot share data across institutions, then sharing models is an alternative to that. It's a very good alternative, in fact, because you can fine tune using your in-house data and you will get back to about 90% performance in these tasks. We have verified these results in the reverse direction as well, training on partners' healthcare data and applying to partners' healthcare data, training on University of Washington training data and applying to partners' healthcare data, and then doing the same combinations as before, either pooling the training sets or building on an external model by fine-tuning. The results are consistent. Since we have a variety of node types in the University of Washington data set, we explored which one of the partners' healthcare data sets would provide the best source for transferring to each of the node types. And perhaps this will come as a validation of intuition for the people in this group, but 2014 data set, which consists of longitudinal medical records and contains progress notes, doctor's notes, nurses' notes, admission notes, communication with patients, and lab results, and many other varied types of notes, serves as the best source in this experiment for 7 out of 10 of the read up node types. 2006 partners data and 2016 partners data also performed best on some of the node types. The remaining 3 they shared, basically. This begs the question of what makes a good source for a transfer. Do we care only about node type similarity or distribution of entity types, or is it something else that we need to consider? And I look forward to exploring that with the community in future shared tasks and workshops. This brings me to the next scientific challenge I'd like to highlight in this presentation today. That is complexity of the domain. Clinical domain is quite complex, and I'll try to explain this with some examples from my past work. The first example I have in mind is one of obesity classification. So given a single note, can you determine whether a patient is obese or not? And the answer being yes, no, maybe. We work with 2 obesity experts to define this task. The 2 obesity experts worked at the same institution and even had offices next to each other in the same institution. So you can imagine they saw similar patients, they served similar demographics, and they had similar background knowledge. That being the case, still getting them to agree on textual and intuitive interpretations of the note that they read was a challenge. The agreement was quite low in the beginning until we made multiple rounds of iterations of the annotation guidelines to make sure textual meant textual. But you know, when you say textual, we're talking about just read the text and tell me what it says. And that's never really the case when you're working in the clinical domain. When the doctors read a note, they are applying their intuition and their background knowledge to it in order to interpret it. So they have other information that you cannot assume that is brought into the task. Another example is the psychiatry task. Here we were working with symptom severity classification, and our first consideration was to find each symptom and to classify it and then maybe create a timeline of symptom severity for a patient. The time element in the note creates so much complexity that it was in fact much more manageable at this point in the development of annotations for NLP systems to focus on lifetime maximum symptom severity, taking the time element out of the equation. For heart disease risk factors, finding all the risk factors was interesting and required some domain knowledge, of course, as the previous tasks. For adverse drug events, one of our biggest challenges was differentiating adverse drug events from the reasons for medication extraction, which is in fact a perfect example of ambiguity in the clinical NLP domain. So complexity factors are domain knowledge, and even when you overcome the domain knowledge and work with the annotators to generate a task that is accessible and reliably reproducible by NLP systems, sample sizes of the notes and the observed phenomena may present a challenge. Now, I want to tell you more about this particular complexity factor in the next section. The task that I will use for this discussion is adverse drug events extraction from discharge summaries. We defined this task on discharge summaries in 2018, and we focused on extraction of entities such as drugs and their attributes, and the linking of their attributes to the specific drugs. One good thing about adverse drug events is that they're rare events. That's a really good thing for humankind, because when adverse drug events happen, they can be really, really bad for the person in question. So I'm really glad that adverse drug events are rare events, but this is a problem for NLP people like us who rely on the gold standard and sufficient number of samples for the desired phenomenon to be observed in our data set so that we can later recognize adverse drug events and even recognize them before they happen and prevent them from happening. For generating gold standard for an NLP task, your best practice would be to draw nodes at random from a large data set so that your representative sample down the road will be useful for generalizing to the bigger population of nodes that you drew from. But if you are working with rare events like adverse drug events, a random sample would very likely contain very few instances of the phenomena that you're interested in and would not be useful for supporting the application that you're working towards. In order to cleverly select the samples that represent adverse drug events, in our case, we used ICD-10 codes. There are ICD-10 codes that are assigned to nodes if they contain an adverse effect. However, we found that even those nodes may not specifically mention the adverse event that we were interested in. Therefore, even after drawing nodes with ICD-10 codes, we had to manually screen to confirm presence of mentions of adverse events. Having carefully selected the samples to annotate, we found that ADEs were still relatively rare in our corpus. There were 26,000 drugs in our corpus, and there were 1,500 ADEs. Furthermore, the inter-annotator agreement on ADEs was lower than inter-annotator agreement on other categories. If you see here, for ADE, when we compared one annotator to the other, we got an F measure of 64%, whereas for every other category, inter-annotator agreement is higher. The second lowest is reasons for medication administration, which is at 70s. Then the rest of the categories are at F measure 80 or higher. It turned out in our case that ADEs and the reasons for administration of medication were frequently confused for each other. That's why the inter-annotator agreement for the two of them were lower than the other ones. ADEs and reasons for medication administration are both medical problems, and they are differentiated from each other by the way that they relate to the drug. ADEs are the outcome of having used the drug. Reasons for administration are the reasons for which a medication is given. So differentiating them requires careful consideration of the context in which they are used, and perhaps use of some contextual information to make the correct interpretation. Despite the limited sample sizes in some of the entity categories and the ambiguities of certain categories of entities with each other, systems did still quite well over all categories in the task. For all of the concepts in medication and AD extraction, we were at 94% F measure, and that's for the best system. And for relations linking the attributes to their drug, we were at 96%. The average of all systems that were submitted to that shared task was at 84% for concepts and 81% for relations. Looking at individual categories that are captured in this task show that for most of the categories, we are performing really, really well with high in 90%. But the category of interest, adverse drug events, is lagging behind with the best performing system, achieving about 60% F measure. The second most challenging category of concepts to extract in this task are the reasons for medication extraction. As I mentioned before, reasons for medication extraction and adverse drug events were frequently confused for each other in this task, and that's because they are in fact ambiguous with each other, and they require context to be differentiated from each other. Additionally, analysis of adverse drug event errors by the systems showed that many of them required inference across sentences and inference across paragraphs in order to identify as adverse drug events. Then they required use of domain knowledge to be able to recognize when the mention of a medical problem was due to the use of a certain drug. These observations really highlight some of the directions we may want to pursue to continue improving the state of the art in clinical NLP. But we can also stop and celebrate some of the accomplishments until now. We have come a long way. We have improved access to data and inspired many other institutions to do the same. Many more institutions are contributing their data to shared tasks and making their data available for other research purposes. We have also improved availability of gold standard data that enable both building block NLP tasks and clinical applications so that state-of-the-art can be continuously improved. I think these are very important accomplishments. Now we need to keep our eye on the next set of challenges that will take us to the next level. Variability of data and what that means for building systems that generalize. Data imbalance and what that means, especially if we are interested in phenomena that are rare but critical to capture and extract from clinical notes. Ambiguity, inference, and domain knowledge, how they affect our solutions and how we can best incorporate them into our solutions. Our ongoing shared task built on our past experiences. We have already completed a shared task on medication disposition extraction that we collaboratively prepared with IBM. We have just completed the evaluation period of the task of social determinants of health extraction from MIMIC and from University of Washington notes. And this week, we are in the process of evaluating clinical note understanding on MIMIC notes, which is a task of matching primary diagnosis with the plan of care for a patient. Going forward, our goal is to continue improving access to information and to explore interactions of different domains of data with each other. For example, there's a lot of health information on Twitter. How do we combine that with electronic health records and still manage the privacy concerns so that we can have both the patient perspective on what's happening and the doctor's perspective on what's happening to the patient? How about combining different modalities of information that is captured in the hospitals so that we can build even better and more accurate representations of patient state? And of course, all these need to be done with generalizability in mind. Our systems need to be able to be used across multiple institutions, across multiple departments. And those are grand challenges for us to keep in mind as we move forward. I thank you all for your attention. And I'd like to also take this opportunity to thank many, many people who contributed to the shared task over the years and to the sponsors that made it possible.